The anterior femoral cutaneous nerves are comprised of the medial and intermediate branches, and they arise from the femoral nerve quite high up around the femoral triangle. AFCN do not extend below the kneecap. They supply sensation to the anterior and medial thigh skin, but also to the fascia lata of the thigh, which blends with the knee joint capsule and its connections to the femur, tibia, and patella. They are very commonly involved in anterior knee pain, anterior thigh pain, post-surgical numbness, and diffuse thigh discomfort that is often wrongly attributed to the hip arthritis or lumbar spine pathology. The pain will usually be described as burning or aching, and patients will often say it is everywhere but nowhere, as it is hard for them to locate. Oddly, they are often very surprised when you can find their pain by following the course of the nerves, and especially so at the fascial punch points. Symptoms may be aggravated by prolonged sitting, movements that use the quadriceps such as hip flexion and knee extension, or even tight clothing over the thigh. As these are purely sensory nerves, there is no associated weakness and no change in the patellar reflex. If you are treating patellar pain, you may need to combine these with LFCN and saphenous nerve interventions, which we will discuss in their individual modules and together in a knee-focused session. Unlike other nerves, such as the femoral and saphenous nerves, which can be compressed along their course between structures, these branches behave quite differently. Their primary point of vulnerability is where they transition from a deep layer to a superficial one, specifically where they perforate the fascia lata. This is what we refer to as a fascial punch type of valet point. The nerve travels distally within the thigh, deep to the fascia. At its perforation point, it passes through a small, inextensible opening in the fascia, and then changes direction as it becomes superficial. Because this opening cannot expand, any movement that alters the geometry of that hole, such as hip positioning, can cause the edge of the fascia to tighten around the nerve. Over time, this can lead to a chronic constriction injury at that exit point. In terms of surface anatomy, we can estimate where these perforation points occur, but they do vary between individuals. The intermediate femoral cutaneous nerve typically becomes superficial, around 8 to 10 centimeters below the inguinal ligament on the anterior thigh. The medial femoral cutaneous nerve tends to perforate slightly lower and more medially, at approximately 10 to 15 centimeters below the inguinal ligament. These are only guides. Palpation is essential to identify the exact symptomatic point in each patient. This placement is important because there is no value in providing superficial PIT to target these nerves in the first 10 centimeters of the thigh. Just like there was no value in supplying PIT superficially at the femoral triangle, as the nerve is on the deep side of the fascia there. This is an image in cross-section of the mid-thigh. The most apparent nerve and vessels are the saphenous ones, in the adductor canal. We will rotate the leg into the frog's leg position to get a better look at the medial aspect of the anterior thigh. Remembering that sartorius runs like a sash across the thigh, most people's intermediate branches will be superficial by the time they cross sartorius. Off the edges of sartorius, you can expect a more medial branch to be present as well from the medial cutaneous femoral nerve. There will generally be a lateral branch off the lateral edge of the muscle too. The lateral branch comes from the lateral femoral cutaneous nerve, which, despite the name, is not a branch of the common femoral nerve. We will shortly cover, in depth, how and where to inject to reduce pain arising from the anterior femoral cutaneous nerve branches. For educational purposes, here is an ultrasound image of the anterior thigh, around 1/3 of the way down from the inguinal fold. We are positioned over sartorius. Depending on the quality of the ultrasound unit used, you may see the cutaneous nerves. Regardless, if you were to target this fascial layer over and off the medial edge of the muscle, you would find the AFCNs at a depth of around 1/2 centimetre. The LFCN will also have a branch off the lateral coast of sartorius in the same plane.